Hello guys, welcome back to ultrasound teaching videos with Dr. Arshad Mawan. Hope you're all okay. Hope you're all enjoying your life. Hope you're all practicing ultrasound and enjoying it, and also enjoying my videos as well. Today my topic of discussion is splenic nodules. Splenic nodules are variable. It is subdivided into micronodules and nodules. If nodular size is 1 to 3 centimeter, that would be considered as a real nodule or splenic real nodule. The size of the splenic nodule is less than 3 centimeter, then it would be considered as micronodule. So sometime you will come across micronodule, sometime you will see nodular pattern within the splenic parenchyma. There are multiple causes of the splenic nodules. If the case is already known, like there is lymphoma or there is tuberculosis or there is sarcoidosis, and patient has the history of all these three diseases, and you could see nodules on the spleen, so it would be definitely due to these three diseases. It could be secondary to tuberculosis, or maybe secondary to lymphoma, or maybe secondary to sarcoidosis. But if the history is not available, then you have multiple differentials with you, a wide variety of differential. So keeping the history of the patient in view and other complaints, you can suggest different diagnoses. There are multiple diagnoses, there are multiple differentials for the splenic nodules. On the top list, there are infections, especially Mycobacterium tuberculosis, histoplasmosis. These are the commonest one. Bacterial infections are very common, causes microabscesses, and beside this, lymphoma and metastasis disease are also on the list. Nodules happens to be of different size. As I mentioned earlier, there may be micronodules, there may be nodule larger than 3 centimeter. Micronodules may be of sub-centimeter, especially can be seen in tuberculosis and one particular form of tuberculosis which is called as Millery tuberculosis. Beside this, this micronodularity you can also observe in lymphomatic patients as well, when there will be a micronodules scattering within the splenic parenchyma. Sometimes metastasis will also appear in micronodular form. So the important thing is a report writing. While you are scanning the patient, you can observe, you can see whatever there is, and in your mind you can diagnose all the things properly. But the main thing is how you can convey all these messages to your colleagues, to your surgeon, to your medical colleague or medical specialist. So that's why report writing is very important. Before writing the report, make sure that you will be equipped with all the information. You should have the previous history of the patients with you. You should have all the other relevant information with you. If the patient is already diagnosed tuberculotic or lymphomatic or any other malignancy, so you should have all the information with you. While on the report, you must mention where the spleen location is. Sometime, like because of situs problem, the spleen may be in its right quadrant, so therefore you have to mention that splenic location is within the left quadrant. And beside this, you have to mention where the lesion is. Lesion is in the upper pole, in the middle pole, or in the lower pole, and mention the characteristic of the lesion. Lesion is small or large or multiple or single, or whatever the characteristic is. It is hypoequic, hyperequic, echogenic, or is called calcific foci. After writing all these information in the description, your conclusion should be very smart. In the conclusion, you mention that these are the lesions in the spleen with the splenic enlargement or splenic normal, or spleen appears in normal size. My differential is so and so. So while writing the differential, do not write all these differential which you have learned on the table and which you have seen on in the book. You should have to be very smart while writing the differential, keeping the patient history and the characteristic of the lesion on the ultrasonic in view. Make your differentials very smart. It would be good that your differential should be up to 3 diagnoses, and if you can extend, you may go up to 5. but it is better to have the three diagnoses with you. As far as the splenic lesion is concerned, these are very easy, nothing to worry about. As I mentioned, you can start on the fingertips. You should have to have the information of the patient with you. If you have, well and fair enough, and if not, so you could just think of these five differential. It could be a tuberculosis, or it could be infectious, it could be abscesses, it could be lymphoma, or it could be metastatic disease, and certain other diseases are, which I will discuss on these videos. So let's start watching all these. There are multiple causes of splenic nodules, include infectious causes, inflammatory causes, malignant causes, and some other causes. In the infectious causes, tuberculosis is on the top, pyogenic abscesses, histoplasmosis, candida abscesses, cat scratch disease, and pneumocystis carinii. These are all the infection which causes splenic nodules. In the inflammatory condition, sarcoidosis is one of the condition in which you can see nodules within the splenic region. So far the malignancy is concerned, lymphoma is the major cause of the splenic nodules. Sometimes they will be marked splenomegaly, or it may appear as a single or multiple nodule within the splenic parenchyma. Metastasis or metastatic deposit can also involve splenic region. In the other causes, gamma antibodies and Gaucher disease are the common one. Splenic tuberculosis. Splenic tuberculosis is usually caused by pulmonary tuberculosis because of the hematogenous spread. It may involve liver, it may involve spleen, and their presentation on the spleen and the liver is usually in the form of granulomas. Depending upon the size, sometimes it appears large, sometimes it appears small, but you can come across small nodules in the liver and the splenic parenchyma in post primary tuberculosis. Tuberculosis is of three types: primary tuberculosis, post primary tuberculosis, and secondary tuberculosis. So in the presentation, you can see the patient will be having a chest or pulmonary tuberculosis. Their radiograph will show tuberculotic findings, and you will be having other investigations with you. Keeping that in view, if patient is already diagnosed tuberculotic and you come across with any splenic nodule, so this would be certainly tuberculotic nodule. So tuberculotic nodule on the spleen give rise to different presentation. It may appear as a single large mass with cystic degenerative changes. It may appear as a small tiny foci evenly distributed in the splenic parenchyma, and that is usually seen in miliary tuberculosis. So these are certain patterns you can see and you can appreciate on the ultrasound imaging. When you appreciate all that, you should have to be very carefully, you should carefully write the report for that, and also mention that the patient previous history shows tuberculosis, pulmonary tuberculosis. Keeping that in view, this nodule, this splenic nodule, suggestive of pulmonary tuberculotic secondary disseminated nodules. You can call it post primary tuberculoma. You can also mention it as a reactivation of pulmonary tuberculosis, which is presenting on within the splenic parenchyma. So these are all the pattern you can appreciate on the spleen. So we have certain images with us. It will definitely help you out to understand how tuberculosis appear on the splenic parenchyma, how many types of pattern you can appreciate within the liver parenchyma or splenic parenchyma, especially in particularly. So these slides are related to splenic nodules, which are due to tuberculosis. So let's start watching these images for your better understanding. On this ultrasound image, you can see dense calcification. These are multiple dense calcification with acoustic shadowing is visible on this image involving the lower pole of the spleen. These calcification are granulomas. These are also called as healed granulomas. Patient had the history of tuberculosis in the past. Superior to these calcific foci, you can see an hypoequic area indicated by white arrowhead. This area is actually the reactivation of the primary tuberculosis. Mention on your report the characteristic of the hypoequic region, mention the size, and also mention the dense calcifications. In the conclusion, give your differentials as healed granuloma associated with echo-poor lesion suggestive of reactivation of tuberculosis. Correlation with previous record and further workup for tuberculosis is suggested. On this ultrasound image in the superior pole of the spleen, you can see a well-defined cystic lesion having calcific wall. You can see calcified wall and also dense calcific foci within the cyst. Low level internal echoes are also seen. Beside this, you can see these calcific foci casting aquastic shadowing. Patient history showed tuberculosis and presented with complaint of fever, night sweats and weight loss. Again, this feature suggests reactivation of tuberculosis. Mention the size and site of the lesion. Give its dimension. Three-dimensional measurement should be on your report. Give its characteristic. Keeping the patient previous history and record in view suggests this tuberculosis. This lesion suggestive of tuberculosis and a reactivation of the tuberculosis, and further workup for the confirmation of post-primary tuberculosis also mentioned on your report. This is the image of young patient spleen with the history of tuberculosis. Look at the spleen. It is enlarged in size. Its parenchyma is interrupted by multiple, rather numerous, tiny hypoequic lesions. These lesions are not greater than 0.1 centimeter in size. These are less than 1 centimeter, or you can call it sub-centimeter, and evenly distributed in the splenic parenchyma. This is miliary tuberculosis. Miliary tuberculosis will appear as such in the spleen. In the lung, on X-rays, it will appear as faint calcific foci, but on the spleen, under the ultrasound beam, it will appear as hypoequic. Mention on the report that multiple hypoequic tiny lesions are seen interrupting splenic parenchyma. In the conclusion, mention that features favor miliary tuberculosis. Further workup and correlation with the X-ray and sputum AFB is recommended. Here on this ultrasound image, the presentation of miliary tuberculosis is totally different. In the last image, you have seen multiple tiny hypoequic lesions, while in this image, these are calcific echogenic lesions. This presentation depends upon the age and duration of the disease. In acute phase, the lesion will appear as hypoequic, while in later stage, due to dystrophic calcification process, calcium will start depositing in the lesion, hence appearing echogenic. Look at its distribution. These are evenly distributed and interrupting entire splenic parenchyma. Mention on the ultrasound report that splenic parenchyma is interrupted by multiple echogenic foci of sub-centimeter in size. In the conclusion, give your differential as granulomas, most likely miliary tuberculosis. Correlation with other imaging is suggested. This slide is of the same patient. Magnified view of the image shows multiple dense calcific foci of less than 1 centimeter in size. You can label it as a sub-centimeter foci as well. Many of the people prefer to write down as an highly echogenic foci, or you can write down as a dense calcific foci. Both are same. Entire parenchyma is involved. It is very important to mention the location, whether the upper pole is involved, mid pole is involved, lower pole is involved, or entire parenchyma is involved. Here in this case, entire parenchyma is involved. No cystic or other solid lesion is visible. Patient has already miliary tuberculosis confirmed on chest radiograph. Always mention in the conclusion for the correlation of previous history and medical record. This patient is on immunosuppressant drugs due to AIDS. Immunocompromised patients always prone to different diseases, particularly tuberculosis. This presentation is atypical for the tuberculosis, but with serial imaging and other investigations, it was confirmed tuberculosis. In this image, multiple calcific foci are seen with variable sizes and shapes. Again, entire parenchyma of the spleen is involved. Patient history and previous diagnosis will help you to diagnose confidently on ultrasound imaging. Sarcoidosis. Sarcoidosis is a multiple organ, multisystemic disease. It is caused by accumulation of inflammatory cells within the skin, within the lymph nodes, and within the lungs. So it gives rise to different presentation. It has multiple different presentation on the chest radiograph, on the other X-ray imaging, on the CT scan, and on the ultrasonography. On the ultrasound, within the spleen, if you come across any lesion, any nodule, there is a possibility of sarcoidosis, but make sure you have the history of the patients available with you, because there must be some other investigations available to you. There must be some other information available to you which would be mentioning that the patient has already sarcoidosis. If patient has already sarcoidosis and you come across any nodular pattern within the splenic parenchyma, so that would be definitely splenic nodule due to sarcoidosis. So before writing your report, must ask the patient for the relevant history, and also look for the other investigation. And then after confirming that patient has already sarcoidosis, always look for the spleen and the liver as well. So there may be presentation on the both side. And if you come across any nodule within the splenic parenchyma, mention it characteristic, and then write on your report that your differential is sarcoidosis, but correlation with other investigation and previous medical record is recommended. So let's start watching all these images. I'm sure this will help you to understand how we can appreciate sarcoidosis on the ultrasound imaging. On this ultrasound image, you can see spleen is enlarged, and within the splenic parenchyma there are multiple calcific foci visible. These are sarcoidosis. Sarcoidosis is multiple organ, multiple system disease. It causes inflammations of the different organs and also lumps in various organs, especially in the lungs and on the skin. On this image, spleen is enlarged. Multiple tiny calcific foci are seen in the splenic parenchyma. Though it looked like miliary pattern, but always remember, miliary disease will show numerous foci, while in this case few calcific foci are visible. Besides, patient has already has nodule on his lungs and skin, so these calcific foci are definitely sarcoidosis. In the presence of previous record and other investigations, the ultrasound features are suggestive of granulomatic nodules, likely sarcoidosis. This is a CT scan image of sarcoidosis patient. Ultrasound image has been already discussed. For the confirmation of diagnosis, CT scan was performed for that patient. On this CT image, you can see liver is also enlarged with multiple tiny calcific foci in its liver parenchyma. These foci are sub-centimeter in size. On the left side, spleen is enlarged, having multiple calcific foci in its parenchyma. In this vicinity, no other lesion can be seen. So these were calcified nodules of sarcoidosis, and CT scan has confirmed the diagnosis. Splenic artery calcification, a very rare condition, but still you come across, and you can see these calcifications in the splenic veins, in the splenic arteries, that are arterial calcification. Whenever spleen is involved, this is likely due to sickle cell anemia. In sickle cell anemia, there is a great chance and possibility of splenic artery calcification. But beside this, you have to keep in mind that atherosclerotic disease or atherosclerotic conditions are the condition where you can see calcification within the wall of arteries and veins, and you have to look for the aortic calcification, you have to look for the carotid calcification as well. So therefore, when you come across calcification within the splenic region, which happens to be in a linear form, this would be having a very particular linear elongated characteristic or shape, so this would show that these are splenic calcification. When you come across splenic artery calcification, make sure you should put the Doppler signal on it and to confirm whether the lumen of that artery is stenosed or not. If there is any stenotic pattern, you also mention on the report, so that the GP or the general surgeon or the vascular surgeon should also consider some other vascular abnormalities as well. How it will appear on the ultrasound imaging, how we will write the report, these few images will definitely help you to find out and to understand splenic artery calcification. So let's start watching these images. On this ultrasound image, again calcification can be seen, but these calcifications are linear in shape. These are splenic artery calcifications. This calcification causes narrowing of splenic artery, eventually resulting into infarction of the spleen. These features are common in atherosclerotic patients. There must be aortic calcifications as well. So carefully scan the aortic region and other major vasculature of the body. Mention on the report the size and shape of the calcification. Mention the Doppler flow in the splenic artery, and further advise angiogram to rule out stricture or stenosis of the vasculature. Splenic abscess. As abscess caused by any of the microorganisms, especially streptococci, staphylococci, or any other organism, caused by even sometime due to fungi, candida or candidiasis, it has its own particular presentation within the splenic parenchyma. As you all know that abscesses may occur anywhere in the body, and when it appears in the liver or in the splenic region, it confuses with some other differentials as well. So therefore care must be taken while you are looking for these nodules in the splenic region. In the splenic region, micro abscesses may occur. Abscess presentation on the ultrasound, it appears to be a hypoechoic or sometimes cystic with a thick wall with internal echoes. So these are the characteristic features of the abscesses on the ultrasonography. But when we are talking in respect of micro abscesses, especially in candidiasis, so it gives rise to small nodular pattern. There are two type of the words used for these micro nodules, these presentation of candidiasis. One is called as target lesions. Target lesions are, you can also call as bull eye signs. So these two signs will appear within the splenic parenchyma, so you can consider micro abscesses as well. But beside this, you should have to have the other relevant information and investigation with you to confirm that these are really the micro abscesses. As you know, the pattern of micro abscesses are confused with some other differentials as well. So on the ultrasound imaging, the tuberculosis will also appear and will give rise to the same presentation. Beside this, the lymphoma, which is another disease, is a malignant disease. It also gives rise to may present as a target lesion in the splenic region, and sometimes metastatic deposits also appears in target lesion. So there are wide differentials for the target lesion. So you must be very careful, because it depends upon the history, and you should have to have the previous history of the patient with you and other investigations as well. So keeping all these information in view, let's start watching these videos, and on these images there are particular characteristics of the micro abscesses, how it will appear, how we will appreciate, how we will write the report. Let's start watching these images, and I'm sure you will be able to understand how micro abscesses will look on the ultrasound imaging. On this ultrasound image, spleen is clearly visible, especially its upper pole. A small hypoequic areas can be seen in the upper pole. These are localized collections and these are called as abscesses. Rather, you can call it micro abscesses. These can be due to bacteria or maybe caused by parasites or even fungi. Take the measurement of these abscesses in 3 dimensions and estimate its volume. It is always good to give the volume so that it become easy to evaluate whether it required medicinal treatment or need any surgical intervention. In the conclusion, mention multiple micro abscesses with the largest having volume of 3 ml or 4 ml or whatever the volume is. Give that volume. Again, this another slide shows micro abscesses. You can appreciate the spleen. Within the splenic parenchyma, there are multiple hypoequic small lesions. These abscesses sometimes appears as target lesion, centrally echogenic area surrounded by hypoequic halo. As you can appreciate, the largest lesion is centrally echogenic, surrounding by hypoequic area. However, margins are slightly irregular. If abscesses are enlarged in size, it will appear irregular and more hypoequic and cystic. But microabscesses appear as target lesion and they are usually small in size. Target lesions are considered to be the characteristics of fungal infections, likely Candida albicans, and you can call it as candidiasis. On the report mentioned, multiple target lesions are seen. Largest measurement or measuring give its measurement with the volume of either 5 ml or 10 ml, whatever the volume is, mention it on the report. Lymphoma. Lymphoma is a malignant condition, and there are 2 types of lymphoma: Hodgkin lymphoma and non-Hodgkin lymphoma. Lymphoma can involve almost all the body organs, especially liver and spleen are the commonest one. Patient will give rise to symptom of tiredness, fatigue, malaise, body aches, and nodular enlargement of the body. Sometimes these symptoms will be confused with less serious condition. So therefore, when you come across all these points and all these symptoms, carefully scan the patient, carefully examine the patient. So far, the presentations of the lymphoma on the ultrasound is concerned, it gives rise to multiple presentations. It may appear as a small nodule, it may appear as a large nodule, it may appear as a single nodule, or it may appear as a multiple nodular pattern. Keeping in view of T lymphoma and B lymphoma, the presentations on the ultrasound imaging are still different. How it will appear on the ultrasound imaging, there are few images available to you, so I'm sure you will be able to understand how it will appear on the ultrasound imaging. But again, I would say, and I will give stress on this point, that always look for the previous investigation, ask relevant information, look for the relevant history and other investigation as well. If the patient is already diagnosed lymphoma, so definitely the splenic nodule would be of lymphomatic type. So scan the spleen, mention the lesions and the area and the locations of the nodules within the splenic parenchyma, and give your possible differential. So let's start watching these images, how the lymphoma will appear on the ultrasound imaging. Here on this slide you can see spleen is markedly enlarged and its parenchyma is again interrupted by multiple small hypoequic nodules of variable sizes. It looks as it was a miliary tuberculosis, but in actually history favors lymphoma because spleen is enlarged, liver of the patient was enlarged, multiple nodules were enlarged, so this was typical case of lymphoma, and its spleen is interrupted by multiple hypoequic nodules of variable sizes. So these nodules are actually lymphomatic nodules. So give its size, give its location, and mention that keeping the previous history of the patient in view, these are suggestive of lymphomatic nodules. This is another slide of the lymphoma. Here you can appreciate the spleen is enlarged and its parenchyma is interrupted by multiple hypoequic round nodules. These round nodules are arranged in such a fashion like it does not fall in any other characteristic or in any other disease characteristics. So these are definitely lymphomas. This will appear multiple in number, and their size would be smaller. Sometimes it may get enlarged up to few centimeters, but so far this image is concerned, you can see it is from 1 to 2 centimeter in sizes. So mention that spleen is enlarged and there are multiple hypoequic nodules can be seen in the liver, in the splenic parenchyma, and in your diagnosis mention that these could be lymphomatic nodules. Further workup for the lymphoma is suggested. Just for the understanding, this another slide is mentioned and this another slide is shown. It shows a well-defined hypoequic with centrally cystic areas lesion arising from the upper pole of the spleen. In that case, spleen is slightly enlarged. This is actually a non-Hodgkin lymphoma. Lymphoma is of two types. One is called as Hodgkin and another is non-Hodgkin. So this is non-Hodgkin lymphoma, and this appears sometime as a big large mass, big large nodule. Usually in this case there will be multiple organs involved. There may be nodular lesion in the spleen, in the liver. A lymph node would also be enlarged. Lymph node of the other area, especially groin region, inguinal region, and the neck region would definitely be responsive. In this case, you can see a well-defined hypoequic mass with the cystic lesion can be seen arising from the upper pole of the spleen. So this is non-Hodgkin lymphoma. So you have seen all types of lymphoma presentation. It could be small in size, it could be multiple in size, it may be numerous in size, it might involve all the splenic region, it might involve only one part of the spleen. Here in this slide you can see this is also B cell lymphoma, and here the superior part of the splenic region is involved. Spleen is enlarged in size. Parenchyma of the spleen appears heterogeneous, and this shows that there is some disease process going within the splenic parenchyma. A small hypoequic lesion arising from the midpole of the call it, or you can say center of the spleen. So central splenic lesion can be seen here. So this is B cell lymphoma. Metastatic deposits. Metastatic deposits also involve the splenic region. As you know, mets can involve any organ of the body. So how it will present on the splenic images, especially so far the mets are concerned, it has its own particular characteristic and particular features on the ultrasonography. That happens to be a target lesion. Target lesion, or you can also call a bull eye sign. So far the target lesions are concerned, there is a great differential for the target lesion, which I'm gonna have a separate, which I'm gonna make a separate video for the target lesion differentials later on after this video. But so far this splenic metastatic characteristics are concerned, you should not confuse with other features. You must have to have the differentials in front of you. So which I have already mentioned, that differentials could be lymphoma, could be sarcoidosis, could be microabscesses, candidiasis. So all this has already been discussed. So now start watching these videos and appreciate how the melanoma metastatic deposits will appear, how the colonic carcinoma metastatic deposits appear on the ultrasound imaging. Hopefully these images will help you to understand metastatic disease in the liver, in the splenic parenchyma. On this ultrasound image, spleen is enlarged. You can see spleen is grossly enlarged and its parenchyma is interrupted by multiple hypoequic nodules of variable sizes. This presentation you have already seen in miliary tuberculosis, you have seen in microabscesses, you have also seen in lymphoma, but this diagnosis is totally different from the others. These are metastatic deposits. As I already mentioned that previous history, clinical record and other investigations are helpful differentiating these lesions. So this patient had vascular cancer and its seeding and metastatic deposit can be seen in the splenic region. So mention on your report the size and sites of the lesions and also write down that correlation with the previous record and history suggested. On this ultrasound image, splenic parenchyma is interrupted by multiple mixed echogenicity nodules of variable sizes. Radiologically, these lesions are called as target lesion, or it is also called as bull-eye sign. These are actually metastatic deposits from melanoma because the patient had history of melanoma already. So you have already previous report and investigations available with you. Take the measurement of the largest lesion. Mention on the report that multiple target lesions of the spleen with possible differential of metastatic deposits. Clinical correlation and correlation with previous investigation and medical record is recommended. On this ultrasound image, you can see adjacent to the left kidney there is a spleen, and spleen is slightly enlarged in size and ill defined because margins are not clearly visible, but although you can see an echogenic lesion with small cystic degenerative changes within the lesion can be seen. This is actually colonic cancer. Matt's patient was already diagnosed with colonic cancer, and this atypical lesion was found on the splenic area. So this splenic nodule is actually metastatic deposit. So metastatic deposit can be multiple, can be small, can be large. It depends upon the site and the primary cancer. So colonic cancer metastatic appears echogenic. This is CT image and it shows enlarged liver and enlarged spleen. Spleen is enlarged and the lower pole of the spleen shows well-defined hypodense lesion. On the liver, there are multiple hypodense lesions visible. So this patient was already diagnosed as colonic cancer. CT was performed to look for the metastatic deposits and involvement of the other organs. So this CT confirmed the metastatic deposits involving the splenic region and involving the liver region. So this was the case of colonic cancer. Yes guys, this was all about splenic nodule. In the start, I have given you the list which indicates that there are certain reasons for the splenic nodules, including infection, inflammations and some other diseases. You must keep all these points in view. When you are scanning and you come across any of the nodular pattern within the splenic parenchyma, you must memorize all these lists in your mind and ask the relevant history, ask the previous information, and then write your report. On your report, you should mention that what is the characteristic of the lesion, which is the location of the lesion. Is there a multiple nodules, or is there any single nodule, and is there any cystic degenerative changes? Is it cystic nodule or it looks like a solid nodule? Is there any calcification within it or not? Is there any Doppler signal within the lesion or not, or in the surrounding? So these are the information you should have to mention on your report, and after that must give your differentials. As I mentioned you that differential is not too long, it's very easy to understand. Like most commonly, first of all, think for the infections. There will be microabscesses, there may be candidiasis, candida albicans, or you can also think about the tuberculosis. Patient will be having the history of TB. There might be a miliary tuberculosis. If miliary tuberculosis, ask for the chest radiograph and there is a particular pattern of the miliary tuberculosis on the chest x-ray, which appears to be a small tiny nodule evenly distributed in bilateral lungs. Sometimes we can confuse that with pneumoconiosis, but pneumoconiosis and the miliary tuberculosis have certain minor distinctive features. But anyway, if you come across all these minor or small tiny nodularity which is evenly spread within the splenic parenchyma, that is characteristic of the miliary tuberculosis. So miliary tuberculosis and microabscesses. The third thing is lymphoma, but again the patient will give you the history of lymphoma. So if the lymphoma history is available, so definitely this diagnosis is lymphomatic nodule. At the end, must think about the cancer. There must be a cancer. Patient will always be having some other cancerous issues with you, like these in these images you have seen malignant melanoma disseminated to the splenic parenchyma. You have also seen colonic cancer, metastasis of the colonic cancer. You have also seen all that thing. So always equip your report with very quality diagnosis, which could give help to your clinical colleague, your medical colleague, and the patients as well. So I'm sure you must have enjoyed this video. Keep watching my videos, enjoy learning. If you come across any issue or you think there is something to be explained, just drop me a message and I will get back to it. Enjoy these videos with some other topics. We will meet in the next video. Till then, take great care of yourself and enjoy your life. See you then. Bye bye.